So now one of our last stops along the continuum of care, refractory disease. Axel, I know, you're sitting right next to me. I can't help it. Talk to us about regorafenib.
So when we talked about unmet need, I think, when we run clinical trials accrue successfully if we have an unmet need. And at the time when we designed the regorafenib correct study, 2-to-1 randomization against placebo, we targeted patients with an unmet need, patients who had progressive disease or intolerance to 5-FU-oxaliplatin, irinotecan, bevacizumab, and EGF receptor antibody when they were KRAS exon 2 wild type. And the study accrued very rapidly, so the development of regorafenib in metastatic colorectal cancer went from phase 1 publication to phase 3 publication within 2 years, and approval, FDA approval and worldwide approval. Now, the drug is active. Is it as active as that we say, this is a home run? Not at all. And it has toxicity issues, which I think we haven't adequately, didn't have time to adequately address because the development was so fast. There's a lot of push to get the drug in hands of patients in this unmet need situation. So, but what we've learned since, in the last almost 2 years that we have had this drug, and it collated the data of the registration trial because it's also approved in GIST. So we have actually pretty solid clinical data, clinical trial data, is it's very important to look at the toxicity profile, kinetic. When do these toxicities come up? Because sometimes I take kind of issue with our toxicity tables when you see grade 3, okay, 16% grade 3, let's say hand-foot skin reaction, you don't know when it comes, you don't know how long it stays, you don't know how reversible it is. This is how we report toxicities. What we need to educate people about, I think this is very critical, is these side effects, the critical side effects, hand-foot skin reaction, fatigue, come early. They come actually within the first 2 weeks. And so when we have a 3-week on, 1-week off schedule, if you just follow package insert monitoring, you put patient on 160 milligrams, the starting dose, bring patients back after 2 weeks, and that's too late. You need to monitor patients early. You need to see them or talk to them within the first week, at first week point, then at second week, etc. And what we've done in clinical practice more and more also use an escalating dosing schema. I mean, we don't have any randomized data yet, or clinical data to validate that this is better, but I think we need at this point in time to really proactively address the toxicity issues, because it is an active drug. The more I treat patients, the more I see actually outcomes which I would not have anticipated. So we should not deny this treatment to patients based on, we don't know how to manage it. We need to create data, we need to create evidence that this actually is the best way. But early monitoring is critical. Really need to talk and see these patients, probably weekly on the first 2 cycles.
It reminds me of the old capecitabine data, when we would put people on it and say, see you in 3 weeks, and then they'd be in serious trouble.
And you'd see them in the emergency room with dehydration.
Right.
Exactly.
Well, and I think the point here is that this is true, absolutely true in regorafenib, but it's true for other targeted drugs we use, that whether it's sorafenib, everolimus, there are drugs that have important toxicities where we need to be monitoring people early on. And so I would hope, as our oncology community embraces this as the appropriate way to utilize these agents and to work much more closely with patients who are beginning these treatments.
Okay, I'm going to try something. This might backfire on me, okay? I'm going to have you put your hand up when you tell me what your starting dose of regorafenib is, okay? 160.
Selective.
GIST or
You can't go like this.
cancer.
No, GIST is different. So we should point out, though, the GIST toxicity, interestingly enough, does not seem to be as bad as for the colorectal cancer
They have
patients.
more benefit.
And also
You
potentially...
tolerate more toxicity because it works better.
The point you made before.
And or the pretreatment, too. Yeah. So, okay, so we've got 1.5 for 160, 120. Who starts at 120? See, I know where Alan's going to vote because he votes with me too. Who starts at 80?
Often.
Yeah, and then I bump it up once a week.
Bump up once a week, yeah. But I still believe we need to generate data on that.
Yes.
I mean, we really need to see, and that's actually a proposal that's on the table right now.
Sorry, that just might be an area that I can put a plug in for gathering data from the community later, not doing a big, expensive trial. That would be a
not big.
perfect use of that way of using big data, as ASCO's proposed and various organizations are proposing, because lots of people are doing it. So we may as well collect that
And there's
information.
precedent. The imatinib as a good example. Drugs that are better tolerated if you use them and accelerate and up the dose. There again and again we see that with these classes of drugs.
In particular, with an analysis that toxicities come early. It's actually interesting. We have time to toxicity and time to maximum grade of toxicity in regorafenib are identical. So the first time the toxicity hits is the worst toxicity that patients experience. And that's different than oxaliplatin neuropathy, which is not an issue in the first cycle, but it keeps up over time.
But, you know, so I do need to defend why I start at 160. Because, you know, so I think the main point, and I find no issue with starting at a lower dose, except that, you know, those patients have an average progression-free survival of less than 2 months. And I find it very uncomfortable, personally, to experiment within 4 weeks to get to the maximal dose that about 20% of the patients actually tolerate. And it may be the effective dose. We don't know if actually experimenting with lower doses is going to have these patients lose benefit. We do not know that. We do not know that. So, you know, I certainly understand the need to start with a lower dose. I do have issue, though, with the fact that this is a group of patients that has a very short survival, very short progression-free survival, and we do, in the absence of actual data, we are experimenting with a dose escalation schema that has never been proven in any shape or form that actually would have the same benefit.
That's why we need, I actually do believe we need to have a controlled analysis, not a large, let's say, 1,000 per patient non-inferiority, but in a sense, you know, you could also make the argument when you beat patients up to 160 milligrams, they come back after 1 week, and then you have a dose delay for the next dose of another week, your dose intensity actually goes down. So an escalating dosing schema where patients get on a controlled ramp-up dosing, and you might actually eventually have more drug.
Or they refuse to go back on.
And, you know, I'd be interested what others think. At our center, where we have a large drug development program, so we actually would move patients into, we'll give them the option of going to a new phase 1 study, for example, before or regorafenib, for example.
That's acceptable.
Yeah, we do this.
That certainly is acceptable. Frankly, anywhere beyond the second line, you really start losing a lot of value of your treatments, and it would be acceptable to place patients.
And so I think for the patients out in the community who are beyond second line, you know, regorafenib does help some patients for sure, but it's also the time to think about what else is there, because you don't want them to miss the opportunity to get something else.
So this is the perfect